One of the challenges in lung cancer is getting patients diagnosed and staged quickly. And there's now new data out showing that actually millimeters count, in as much as tumours grow, slowly grow, from the smallest T1A stage, in fact through T1B and T1C. This is only a change of a few millimeters, but actually there's now good data to show that as these tumours get larger, survival rates start to go down. So this means an argument that actually we should be getting patients diagnosed and staged as quickly as possible. And across the country, this is very patchy. There are centres that have very well organised systems. Patients get referred in, they go into a very streamlined investigation programme, and they get put through the process in a quick fashion. There are other areas in the country where, for various infrastructural reasons and staffing levels and all sorts of reasons, the processes are slower. So what we thought we would do is, through the NHS England Clinical Expert Group, is come up with an optimal pathway. And we wanted to be challenging and aspirational. We recognised that actually a lot of the hold-up is right at the beginning of the pathway. So we've very much focused on that end of it. For instance, if a GP refers a patient, or if a patient presents through A&E, we want to get them a chest X-ray and then a CT scan within, between 1 and 3 days, and get that CT scan reported, and then get a plan made for investigation of the patient, and get them to diagnostic tests as quickly as possible. Because if we recognise that if we can shrink that initial part of the pathway, then we can get the diagnostic and staging tests done, and we can move the patient through to treatment as quickly as possible. Because even at the moment, on the 62-day wait pathways, those 2 months in effect, for a tumour, gives time for a tumour to grow. So if we can shrink that pathway time down and offer patients with potentially curable disease treatment as quickly as possible, we hope that will actually translate in effect into a survival advantage. Now, there are challenges for different parts of the country, and we had excellent presentations from the Manchester group, who have presented on their work called the RAPID study that they've done, trying to streamline their pathway in the Manchester area, and they've identified, for instance, one of their hold-ups is PET CT. They can't get their PET CTs quickly. They've got everything else working very well, but they recognise they can't get PET CTs quickly enough. Other centres in other parts of the country can get PET CTs quickly, but they might have a shortage of radiologists who can do biopsies, or bronchoscopists who can do endobronchial ultrasound. So there can be different glitches, as it were, in the pathway in different places. So having set down, this is an optimal, aspirational, challenging pathway, then is up to all the local teams to go back and sort of do a stock take of where are they at the moment, what are the potential problems in the pathway, how can they iron these things out, working with their local commissioning groups and the cancer alliances, in order to get the pathway working really slickly.